Okay, good morning, everyone. So we had a new grand rounds today. So we had a special guest today. Is Dr. Alan Aksamit. So he's in Mayo Clinic in Rochester, Minnesota. He has been working there since 1986. He's the professor of neurology and consultant in the Department of Neurology. He was the founding head of the Major Neurology Education Division for 20 years. In the Department of Neurology, he has responsibility for staff in his division and neurological education and neurology clinical teaching and neuropathological lectures. So he teaches multiple lectures in the first year of neuroscience course at the major medical school as well. His clinical and research interests is around neuroinfectious diseases. He has multiple publications that goes from chronic meningitis, GFAP, autoimmune encephalitis, neuropsychosis, progressive multifocal leukoencephalopathy, because of Jakob disease and various viral infections in the human brain. He has recent publications in the New England Journal of Medicine, from the Continuum, for the JAMA Neurology, Journal of Neurobiology, and others of neurology. He was the founding chair of the neuroinfectious disease section at the American Academy of Neurology. And he's a past member of the education committee of the American Academy of Neurology. He's a current member of the committees in the American Neurological Association and the American Academy of Neurology. So we welcome Dr. Aksamit. Thank you so much for accepting our invitation and all the spotlights into you.
Thank you. I appreciate the opportunity to share thoughts with you here today. Thank you for the invitation. When Sergio asked me to talk, I had a great deal of difficulty trying to decide what to talk about, but he wanted me to talk about encephalitis. So I've titled the talk Principles and Examples, and I probably should have titled it more Mistakes that I've made, lessons that I've learned, and surprises that I've had. And that's what I'd like to share with you today, something about the experience that I've had in dealing with encephalitis over the years. And I'll show you some examples, and some old and some recent examples as well. So we're going to concentrate principally on trying to distinguish viral from autoimmune encephalitis, and I'm going to concentrate principally on viral encephalitis. Well, hopefully you'll have a better understanding at the end about sensitivity and specificity of spinal fluid and imaging testing for viral encephalitis, and then we'll learn about the limited treatment options for viral encephalitis, what's there, what's lacking, some things that have been tried, and we'll talk about some off-label treatments because most of the treatments are off-label except for herpes simplex encephalitis. And as a matter of disclosure, I don't have any conflicts of interest or commercial funding or grant funding. So let's start with a definition. First thing is to say, what is encephalitis? And of course, it's an inflammatory process affecting the parenchyma of the brain. It most commonly occurs diffusely in the gray matter, and therefore it leads to clouding of consciousness. It's generally non-purulent. And when we use the distinction between encephalitis and cerebritis pathologically, if there's a purulent reaction, then we generally call it cerebritis, and that's mostly bacterial, TB, and other infections. Whereas with encephalitis, there's not a tendency towards gross purulence. And again, that is generally applied or preferred as the term for viral and autoimmune encephalitis. So we'll move on. There are a number of encephalitis guidelines. I'm not going to go through them with you. I'm happy to send you the information about these. They're somewhat out of date. Most of the guidelines were created in the next generation sequencing era. So they include PCR analyses, but not so much of next generation sequencing that we'll briefly at least talk about. But I can just bring these, I'll bring these to your attention just to let you know that if you are looking for a guideline to help you work through a case, that these are sources that you can use. There are more current ones. There's one from Johns Hopkins that's online. The one that was published by the Infectious Disease Society of America in 2008 has actually been archived. But I will tell you about an autoimmune encephalitis paper that has guidelines in it about trying to approach autoimmune encephalitis, and it's a nice collaboration between many groups who work on autoimmune encephalitis in various parts of the world that put together this nice paper in the Journal of Neurology, Neurosurgery, and Psychiatry last year. So I'd recommend that to you if you want to explore protocols for looking at both diagnosis and treatment of autoimmune encephalitis. I don't know how enthusiastic you are about algorithms, but I'm not very. But this is one that was created by Tom Solomon in the UK to try to help people give a framework for working through a patient who has a problem that is suspected to be encephalitis. And again, I'm not going to go through it with you. There are a number of algorithms that I can send to you. This is one that was created by one of my colleagues. Dr. Toledano here is a neuroinfectious disease specialist as well. And he's interested in molecular diagnosis and put this together for us to try to help with our educational efforts with our students and residents. And I can send that to you if that's of interest to you. This is one that I put together that's just going to be coming out in Goldman Cecil Medicine in the next edition. They asked me to put together a flow chart for diagnosis of encephalitis. So this is here. It's unlegible, and I'm not going to walk you through it, but it just tells you about some of the complexities that you have to deal with when you're thinking about encephalitis. And I'll just kind of draw your attention to them, that they exist. Okay, so let's go next to epidemiology. How common is encephalitis? Is it a frequent thing in the United States? And this is, I think, the best large overview of encephalitis epidemiology that I'm aware of. So it's a little bit old. It was published in 2014 by some of our colleagues at the CDC. They looked at the years 1998 to 2010, and they found on average 20,000 cases of encephalitis in the United States. They estimated that the fatality rate was about 6%, and about 20% of those patients who had encephalitis were thought to be viral. It's probably a little higher than that. And we'll talk a little bit about a few other studies. This is just a chart of several studies that were published again in the last 20 years. And if you look at the one on the top in particular, that came from Mayo here, this was between 2000 and 2012. Among the patients who were thought to have infectious encephalitis, the vast majority were viral encephalitis. About 50% were diagnosed with an infection. About 20% had an autoimmune encephalitis. And this is, of course, at our institution where autoimmune encephalitis has a lot of diagnostic testing and acumen for both defining and treating those patients. And still about 30% of people still have an unknown cause. So the fact that there is no diagnostic proof of the cause of the encephalitis remains still a problem for us. And what we're hoping for is, as we learn more, know more about molecular diagnostics, will lessen the number of unknown cases. As far as recent papers, there are a few that I'll again draw your attention to. There's a nice review by Ken Tyler in the New England Journal from a couple of years ago about viral encephalitis. He did a good job of sort of outlining the different differential for cases both in the United States and abroad. And then Aaron Van Katzen, who's a infectious disease and autoimmune specialist at Hopkins, along with a group of other people in the International Encephalitis Consortium, put together a paper in The Lancet in 2019 that I can send to you again if you're interested in looking at that. But I want to tell the story a little bit about what's changed with regards to encephalitis and how the shift from sort of infectious causes has shifted over to autoimmune disease to some degree. And the big sort of intellectual shift came in 2012 with this paper from the California Encephalitis Project They had 700 cases of encephalitis that they had collected from around the state and other places, and these were subjected to all of the molecular diagnostics available at the time. And what was included in this paper was the idea that they took the samples from the spinal fluid and looked at causes, autoimmune included, with looking at anti-NMDR, NMDA-R and antibodies in the spinal fluid, and found that the NMDA receptor encephalitis was the most common cause that they could identify among the ones that were able to be identified. The other infectious one was enterovirus, and that the anti-NMDA receptor encephalitis was as common as HSV1 West Nile or VZV among the specimens that they tested. So it's equal or around the same as what we would expect for viral encephalitis. So it focused people to look harder for autoimmune encephalitis and suspected encephalitis. I'm going to try to just close this a bit so I don't cover all the slide. In general, infectious encephalitis, in trying to distinguish it from autoimmune encephalitis, has a tendency to be associated with fever and headache, and has an acute to subacute onset of symptoms. So it tends to be a little more rapid in onset than the autoimmune encephalitis. But the overlap comes with behavior, memory disturbance, altered level of consciousness, seizures. All of those can occur in either infectious or autoimmune encephalitis, and both are associated with laboratory signs of brain inflammation, spinal fluid pleocytosis, elevation of protein. This is just a partial list of maybe the most important viral encephalitides that are seen in the United States. Among the flavivirus, the arboviruses, probably West Nile remains the most common one that we see in the United States. I'll have some more to say about that in a little bit. And we're seeing some reemergence now of Eastern equine encephalitis as well that I'll also speak to. Among the non-epidemic forms of encephalitis, herpes simplex type 1 remains the principal cause for encephalitis. Others are listed here, and we'll have some more to say about a few of those. And then enterovirus also causes an encephalitis, although it's more common as a meningitis. And most of the times when enterovirus causes an encephalitis, it's often with neck stiffness as well and other meningeal irritation signs. So enterovirus is a common cause as well to consider. And of course, HIV can cause encephalitis, particularly at primary onset with a meningitis, and then with a chronic hand and other neurological manifestations of cognitive disturbance. And then I include rabies at the bottom because it's still present in the United States, and we'll talk about that a little bit too. The next thing I want to turn to is the idea of molecular diagnostics, and I want to focus on this meningitis encephalitis panel. It's made by the BioFire company, and there are other panels out there, but this one is the one that's most commonly used in the United States. More labs are using this, and it's a PCR-based analysis of spinal fluid looking for infections. It has a bacterial component and a viral component and one yeast that's included, specifically Cryptococcus. The bacterial parts are principally directed at meningitis causes. The viruses are principally directed at encephalitis, but enterovirus is included. And as I've said, that's a common cause for viral meningitis, as is herpes simplex type 2. But doing a panel is a very useful, fast way to get an answer with regards to a wide variety of pathogens, but it does have some potential pitfalls, and I'll show or I'll talk about a few of those. When the panel was tested against standalone testing for encephalitic agents, when you look at bacterial pathogens, again, mostly for meningitis, good correlation, high correspondence with the standalone PCRs. If you look at for viruses in general, again, high correlation good sensitivity with regards to identifying those agents. The one that's the big flaw in this panel is the cryptococcal PCR. And the sensitivity of the PCR in this panel for cryptococcal meningitis is only about 50%. And as you probably know, the antigen testing is about 90% sensitive or 95% sensitive for patients who have cryptococcal meningitis. So this is kind of a flaw and should not be used as an exclusionary test to say the patient does not have cryptococcal meningitis. And if you're thinking about it, you should be doing the antigen testing, of course. Okay. Some other things that are missing from the panel include, of course, all of the arboviruses. So all of the arboviruses that we'll talk about or can cause encephalitis, those require serological testing, and the PCR testing is either not sensitive or not available as a matter of routine. So again, many causes of meningitis that are particularly seasonal or epidemic are not included in the panel. So you can't say, well, patient doesn't have encephalitis because their panel was negative. A couple of other things that are missing from the panel that are obvious is HIV is missing, and also JC virus that causes PML as well. So if you're thinking about those disorders, again, the panel is not the way to go with regards to testing. I want to bring up one virus that is included in the panel. It's HHV6. It's, again, a fairly sensitive assay in the panel. It is picked up by the panel in a high proportion of cases. And in patients who have the correct clinical circumstance for HHV6 encephalitis, it's a great diagnostic tool. Particularly, those are patients who have hematopoietic stem cell transplant. And typically they present with limbic encephalitis. So this is just an imaging, an MRI FLAIR sequence of a patient who had hematopoietic stem cell transplant, developed a subacute encephalitic illness with amnestic syndrome and seizures, and had HHV6 isolated in the by PCR in the spinal fluid, and has this signal intensity in the mesial, temporal, and hippocampal areas, characteristic of this infection in this circumstance. Now, the problem is that HHV6 is also non-pathogenic in many patients because it's chromosomally integrated. It's become clear over the years now that there are actually two forms of two subtypes of HHV6, HHV6A and HHV6B, which are now considered as separate species, and really only HHV6B has been consistently associated with disease in humans or encephalitis. And the problem is that if you do this assay and the patient has an inflammatory response in the spinal fluid and they're HHV6 positive, it's impossible to know whether that's a pathogenically important HHV6 infection or whether this is simply chromosomal integration of the virus in an inflammatory cell that's present in the spinal fluid. And to my knowledge, this is the only place that you can sort this out testing wise is through the University of Washington, although I know there are other labs in the country that are trying to develop assays to segregate these, and maybe you all can educate me more about what's going on in New York. I'm not aware of a lab there that can sort this out. So the lesson here is that if you have a positive HHV6 PCR analysis and a patient has an encephalitis, be very careful about assigning that as the pathogen responsible for the encephalitis in many circumstances because of this non-pathogenic presence. The other one that's kind of a bugaboo is the idea of Epstein-Barr virus. And Epstein-Barr virus PCR, you may recognize, is not in the panel, and it was specifically excluded because of the issues of what's been called false positive. Now, it's not really false positive. It's really a true positive. The Epstein-Barr virus is there. But the problem is that it's not pathogenic in many cases. PCR for Epstein-Barr virus is pathogenic when you have post-transplant lymphoproliferative disorder in the nervous system, as it can happen with stem cell transplants. When patients have CNS immunosuppressed lymphoma, example is AIDS, of course, and there are patients who have immune suppressed Epstein-Barr virus encephalitis. But again, because Epstein-Barr virus is integrated in as an episomal presence in B cells, when there are other reasons for inflammation in the nervous system, Epstein-Barr virus can sometimes be detected by the PCR analysis in the spinal fluid, and therefore sometimes be miscalled as the cause for the patient's encephalitis. So again, I think my caution to you is Epstein-Barr virus can be pathogenic, but it's more common in my experience when you do the Epstein-Barr PCR that it's often non-pathogenic, and it's because of the cells that are from the systemic circulation that carry Epstein-Barr virus into the nervous system, and there's essentially a co-infection. So be aware of that and recognize that it's you have to be very careful about labeling somebody as Epstein-Barr encephalitis. Okay, next I'm going to turn to the clinical use of metagenomic next generation sequencing for the diagnosis. Michael Wilson and his colleagues at UCSF have made a big splash about using this technique for diagnosing CNS infections, and it's really sort of a holy grail of thinking about this problem. It's, again, it's not PCR, but it looks at basically RNA in the CSF and identifies any foreign RNA that's different than the host's RNA, and that RNA that's the host is subtracted out, and anything left is a foreign pathogen. They published their experience in the New England Journal a couple of years ago of 200 patients. The sensitivity that they looked at, they found about a 6% so-called hit rate. In those small numbers of cases, several of them had, or the diagnosis was made solely by the metagenomic sequencing, and it had clinical effect in a number of the patients. So it's really a revolution in technique. It's a useful technique to apply, but there are a few issues. One is cost. Our nominal cost when we send this out for our patients is about $2,500, which in a certain sense, if you're thinking about patients in an ICU setting, neuro ICU, $2,500 is certainly not something that's a big expense. The second issue is the issue about turnaround time, because it's a send out, and as I said, it requires extensive machinery, computational abilities in order to do this analysis. The turnaround time was slow at the beginning. Now it's fairly reasonable. It's about 7 days in our hands, so has sufficient time attachment to the submitting of the specimen to have some impact on clinical decision making. So it's becoming more reasonable. And the third issue is, because it's so sensitive, there are problems with contamination. In other words, if there are any kinds of foreign RNA that get in because of bacterial contamination, fungal contamination, anything in the environment, in the specimen handling or transport, et cetera, those can be amplified and also found. And so it can be a problem with dealing with that. There have been some studies where they've looked at water from the same laboratory that's submitting the specimen to see what the environmental contaminants are, and comparing those and running those on the sequencing to try to sort out the contaminating pathogens. But it still remains a bit of a problem, and one that sometimes leads to difficulty in sorting out what's important or pathogenic. This is just a study that was published from our institution about last year, and it looked at a number of cases, 53 samples from Mayo Clinic patients. They there were reported positive results for 9 patients of the 53. 6 of the 9 were interpreted to be as likely contamination issues for the pathogens that were reported. There were also some specimens that were sent in from the Mayo Clinic Laboratory Reference Practice, and those specimens had similar kinds of problems. Again, about half of those cases, 58%, were interpreted to be inconsistent with the patient's clinical presentation. So a lot of effort goes into sometimes chasing down what turn out to be in the end contaminants from this assay. So you have to be a little careful about interpreting results, but still it's a very sensitive and a very nice way of approaching undiagnosable disorders. Okay, I'm going to stop talking about molecular diagnostics and talk now about some clinical entities. And I can't talk about encephalitis in this year without talking about COVID neurological manifestations. And you are all, I'm sure, very familiar with the neurological manifestations of encephalopathy, stroke, seizures, hypoxic ischemic encephalopathy, and rhabdomyolysis that have been reported with COVID, particularly in the sickest patients in the ICU. But the question is, does COVID cause encephalitis? It remains a little bit of an unknown at this point, and I'll just go through some data about this and talk about it, at least give you my 2 cents worth. This is a study from Germany, 43 patients who came to autopsy who died of COVID. There were clear-cut signs of inflammation, particularly in the brainstem. They found COVID viral proteins in cranial nerves, not within the parenchyma of the brain, not like what we usually associate with encephalitis or direct infection of the parenchyma. And the ability to find these viral proteins was not associated with the severity of neuropathological changes. So there was a dissociation, and it says there's inflammation present in the brain frequently in patients with COVID COVID infection, but not so much in the way of direct parenchymal neuronal or glial infection. This is another study from Boston. They looked at 19 cases of patients who had come to autopsy, and most of them showed hypoxic changes and did not show what one would consider pathological features of encephalitis. So really not very much in their series to suggest that there was direct infection in the patients who died of COVID systemically. And then there's this study that was published last year in Brain from Columbia in New York. And again, inflammatory changes were found, particularly in the brainstem, microglial activation, which is an indication of inflammation commonly associated with viral infection, but not specific for it. And again, looking for specific viral proteins or RNA was problematic in identifying those, and really the in situ hybridization failed to detect viral RNA in the brain. So the conclusion from that was that generally the patients who have neurological disorders, who have inflammation, do not seem to have at least much in the way of direct viral infection of the brain parenchyma responsible. We've become more informed by Avi Nath's lab at NIH, who's looked at also molecular aspects of neuropathology in patients with COVID. And it's become clear that there's clearly microvascular injury. Again, there's inflammation present. There's endothelial infection by the virus, but again, direct parenchymal infection of neurons and glia are lacking. So it's a somewhat controversial subject still. So the question is can SARS-CoV-2 ever cause a meningoencephalitis? And there are reported cases of it, and we can just go over a little bit of data. This is from early on in the pandemic from Japan, a patient who had imaging abnormalities suggestive of limbic encephalitis with mesial, temporal, hippocampal area increased signal on the MRI scan. and that had also a minimal pleocytosis in the spinal fluid, and that they did seem to detect virus in the CSF. But again, the question still remains, is this a direct viral infection, or is this sort of a para-infectious or autoimmune phenomenon associated with the virus? And that still remains unclear. There are other examples of publications in the literature of involvement of the orbital frontal areas. This is just one example, again, with increased signal involving the orbital frontal cortex, suggesting that there's inflammation, which could be coming from, again, the nasal epithelium, nasal epithelial infection, which is well known with COVID, and then entering into the brain, particularly in the orbital frontal area. But again, inflammation is not necessarily proof of viral invasion here. So bottom line is there are imaging, at least characteristics, to suggest inflammation present. This is a meta-analysis that was carried out, published last year, looking for encephalitis as a neurological complication of COVID. And the average incidence of encephalitis they found was low, probably below 1% of cases. When there was encephalitis present, the mortality was relatively high, 13%. But again, in looking at the analysis, it's a little difficult to know whether this represents direct viral infection or, from my viewpoint, more likely a para-infectious immune complication of COVID infection. There are some very well described para-infectious phenomena that are known to occur with COVID now. One is the limbic encephalitis, again, that you can see in this panels A and B, with inflammation involving the hippocampal areas. And then one that's much more devastating, that's severe, called acute necrotizing encephalopathy, previously known or seen particularly in children with influenza, and known as an autoimmune para-infectious phenomenon, not a direct viral infection, but rather an autoimmune activation targeting deep gray structures in particular and causing devastating effects, often with hemorrhagic qualities as well. So we know of these phenomenon, and they're recognized gratefully fairly rare complications, but one can certainly include this into the general category of encephalitis. Okay, I'm going to change gears again and talk about a specific encephalitis case that really recently came to our attention because it was a surprise for me, and we'll just talk about it a little bit. This was a 61-year-old man from Wisconsin. He was from northern Wisconsin, which is part of our care network. He was hunting in late October last year, and you say, well, he's northern Wisconsin, it should be cold. But it was a particularly warm October, this past October, and we had 50s and 60-degree days routinely at the end of October, which is fairly unusual for Minnesota and northern Wisconsin. So he was out hunting. He became ill. He became chilled. His wife had him brought to the emergency room. He was febrile, and interestingly, when his exam was carried out, he had non-focal examination on the neurologic exam, but he had tone that was increased throughout, and I'll talk a little bit more about that in a minute. Spinal fluid was performed. He had an elevated protein. He had a marked pleocytosis with neutrophilic predominance in particular. He had a fairly large workup. We are endemic for Lyme disease here, so that was looked for. He had the meningitis encephalitis panel. That was all negative. He had West Nile antibodies tested. Again, we do have West Nile in our part of the world. IgM and IgG were both negative. Had other testing as well, unrevealing as far as microbiology goes. After a few days, his MRI scan was repeated. This is the second one that was performed and showed some abnormalities here that I'll point out to you. He had limbic encephalitis. At this point, he was unresponsive and intubated. He had mesial temporal area of increased signal on the flare. but particularly prominent were the involvement of the deep gray areas, the caudate, the putamen, the thalami bilaterally, asymmetrically so, with DWI, imaging abnormality in the thalami bilaterally. And again, you can see it on the T2 weighted image as well, with signal involving those deep gray structures. So fairly prominent and relatively unique kind of distribution of involvement. Some cortical involvement as well that you can see on the flare sequences in the occipital lobe as well, and some on the DWI as well. So further evaluation, they decided to do more in the way of looking for viral arthropod-borne or mosquito-borne disorders, even though it was late October. And lo and behold, yes, he was positive for La Crosse encephalitis virus by IgG in the serum, but his IgM was negative. We're endemic for La Crosse encephalitis virus here, so this is suggestive of a past exposure. But the most interesting part was that his Eastern equine encephalitis virus IgG was positive, both IgG and, more importantly, IgM was positive. Other parallel arthropod-borne viruses were negative: St. Louis, Western equine, West Nile virus. And then another one that's emerging in our area, Powassan, was negative as well. That's a tick-borne, arthropod-borne arbovirus. And then Jamestown Canyon was also tested, and that was negative. His spinal fluid was repeated, and for sure his Eastern equine encephalitis IgM was positive, which is diagnostic of Eastern equine encephalitis. IgG was mildly positive. So the other, again, arthropod-borne viruses that were tested for were negative. So this is a case of Eastern equine encephalitis. And the point or the surprise there is that it's present in Wisconsin. And we generally have thought about this epidemiologically as an East Coast disease. There have been recent outbreaks, particularly in Massachusetts, but you have them in New York as well. But we're beginning to see them in the Midwest. And so we're anticipating we'll be seeing more of these viruses appearing that are mosquito-borne in our neck of the woods. There was a fairly large outbreak of Eastern equine encephalitis in 2019, predominantly in the Massachusetts area. And I just put in this classification again to show that Eastern equine encephalitis is one of the alpha viruses, and there is some cross-reactivity between some of the similar viruses, like there is between West Nile and St. Louis encephalitis, for instance. But the La Crosse encephalitis virus is in a different group, and the serological positivity in that in this patient really does segregate these viruses, and again suggests that he was exposed to this virus at some time earlier, that it wasn't a cross-reactivity because of the Eastern equine present. So this is just some, again, I'm going to just try to move this a little bit. I'm struggling to get this smaller. I'm going to get this on the screen. Give me just a moment here to make this smaller on the screen. There we go. This is just some examples of the MRI imaging that came from the Massachusetts group from Mass General, looking at patients with Eastern equine encephalitis, very similar to our case, again with limbic involvement, mesial temporal, hippocampal, uncus area involved, and then deep basal ganglia affected, often asymmetrically affected, thalami, putamen, caudate, et cetera. So fairly frequent and a fairly distinctive pattern on the MRI scan that you can kind of file away as something to help you recognize these cases. When these cases were looked at with regards to treatment, there had been some earlier reports of maybe some success with either IVIG treatment or high-dose steroids in treating Eastern equine encephalitis. And so many of the patients that were in the Massachusetts epidemic were treated with IVIG or high-dose steroids. They looked at this in retrospect, and they thought that maybe there was some less long-term disability when patients were treated. And when they looked at the timing of the initiation of the treatment, it had to be in the first 4 days of the illness in order to have any effect. In our particular patient, by the time his diagnosis was made, he was a week into his illness, and for other reasons, also the worrying about toxicity, he was not treated with IVIG. So there's if you have a patient with Eastern equine encephalitis, it's reasonable to treat them with IVIG in the first 3 days of their illness if you make that diagnosis. So early recognition becomes important. And we'll talk a little bit more about serological testing in the spinal fluid in another example here in a minute. I also want to mention this emerging virus that's, again, beginning to appear in Minnesota. It's called Powassan. It's a tick-borne alpha virus that's present associated with encephalitis. It has, again, a propensity to affect the basal ganglia, sometimes to produce a Parkinsonian syndrome. That's why I think our patient with Eastern equine had rigidity in particular because of the basal ganglia involvement. Again, the evolution of the MRI changes are often late. Often the MRI scan is normal at the beginning of the illness, and repeating the MRI helps to define the problem and the abnormalities that are present. Again, basal ganglia, thalami as well. This is just a map, older map now from the CDC showing occurrence of Powassan as a neuroinvasive disease in the United States. And you wonder, well, why is Minnesota the #1? And I asked my colleague in the Minnesota Department of Health about why were we having so many cases of Powassan virus neuroinvasive disease encephalitis, and he said, well, we developed the lab capability to detect it, and we're getting a lot more specimens, and therefore we're making more diagnoses. So it may be more an effect of laboratory availability and ability to test for this virus, again, to identify some of these unknown cases. But I'll just point out that, again, Powassan is present on the East Coast, it's present in New York, it's present in your neck of the woods, and it's something to think about if you have a patient who presents with encephalitis. This is another encephalitic case that was a surprise to us. A patient was brought in October of one year with a tentative diagnosis of ADEM because of the cord signal abnormality and the presentation with paresthesias in the upper extremity and some partial paralysis of the upper extremity with rapid onset of coma. The initial MRI scan of the brain, again, was normal. And when it was repeated, when the patient was not responding to the treatment for IVIG, it showed these abnormalities, again, involvement of the caudate head, again, limbic structures, mesial temporal areas, and hippocampal areas, and brainstem also involved. And the patient did have brainstem findings on physical examination as well. And this was a bit of a head scratcher, and until we sort of had the idea about the paresthesias, and this was rabies from an unfortunate man who had been chasing bats out of his cabin about 6 weeks earlier to this illness, and then presented with eventually fatal outcome of rabies. So you should think about rabies still. It's present. It's the most common cause in our neck of the woods is transmission by the silver-haired bat, bite by the bat, but other wild animal transmissible cases, skunks and raccoons, can occur as well. Okay, I'm going to turn to West Nile virus because this is still a problem and is still occurring, particularly in western parts of the United States. Of the neuroinvasive forms of this disease, it tends to, encephalitis tends to be the most common. The encephalitis, and for that matter, the neuroinvasive disease, tends to be in older patients and in immunosuppressed patients. Again, encephalitis being the most common. Again, the encephalitis cases tend to be older individuals, 70 years as the median age in one epidemiological study. And the other thing that I'll remind you about is that this is another virus that can cause an early predominance of polymorphonuclear cells in the spinal fluid. So about 50% of patients with neuroinvasive disease with West Nile virus will have polymorphonuclear cells as the predominant cell type at the initial spinal fluid presentation, which can lead to confusion as to cause. So think about it. The other important thing that's was touched on when I talked about Eastern equine encephalitis, but also is really important for West Nile, recently presented at the Academy meeting last week, was this idea that West Nile infections require some time before the IgM and the CSF appears. So this is just some data from old New York data, actually, New York Department of Public Health from 2001, showing that the IgM doesn't peak in the spinal fluid until about 7 to 8 days into the illness. So the point is, if you do the spinal tap and the spinal fluid is early in the course of the illness, it's possible that the spinal fluid IgM for West Nile will not be present. So if you are suspicious about the disease, the lesson there is repeat the spinal tap at least a week into the disease, and again, reassay for IgM. The IgM in the spinal fluid is the diagnostic test for West Nile and the other arboviral infections I've mentioned. PCR can be done for West Nile, although it's relatively insensitive. It's only about 55% sensitive, and it usually has to be done very early in the course of disease. So it's reasonable to do it if you're seeing the patient in the first day or two of illness, but it's not. But a negative result does not exclude the diagnosis in particular. So if it's present, it's specific, but it's not very sensitive is the point. And this is what happened last year in the United States. There were large outbreaks of West Nile in the center of the states. Most of our cases are coming from North and South Dakota. We do have it in Minnesota as well. But Arizona in particular, my colleagues, I was talking to them last week, and they were just loaded with West Nile cases in the fall of last year. It kind of exploded. And again, presumably due to ecological changes and weather-related changes, and we can talk about those if you'd like. But it's still present in the East Coast. It's still present in New Jersey and New York. So be aware it's in your neck of the woods as well. Treatment has been uniformly unsuccessful. Alpha interferon has been used. There was a trial using IVIG that was enriched with anti-West Nile antibodies, that is taken from populations of people where West Nile was endemic and thought to have high titers of anti-West Nile immunoglobulin in the infusions of IVIG. 40 patients were tested. This was recently published and really was of no benefit. Ribavirin has been tried, no benefit. There have been attempts at using antisense RNA treatment, but to my knowledge, it has not been subjected to a clinical trial yet. There's animal data to suggest that it might be of some help. Okay, I'm going to turn to another cause of encephalitis that is something that's again, a common cause in our experience, herpes simplex encephalitis. And I want to point out about this case is the mild nature of this patient. This was a patient who was a nurse, had some epigastric pain, had an unwitnessed syncopal episode at home. She deferred evaluation for it. She'd been to Mexico, so there was concern that maybe she had acquired something there. She had an MRI scan at her local hospital, part of our Mayo network, that showed this little bit of increased T2 signal involving the mesial temporal area on the flare sequence, and was reasonably well, became more febrile, and developed some headache. And when she was initially examined, just had mild attentional difficulty, otherwise a normal neurological exam. So we usually think about herpes simplex encephalitis and say, well, this can't be herpes. It's usually a necrotizing, hemorrhagic, severe encephalitis. And that's true, it usually is, but we've learned more with the PCR analyses now that even mild cases can be manifest. On day 8 in her hospital stay, she became more confused. It turned out that she was in focal status when EEG was performed. Spinal fluid was repeated. She had a protein of 216. She had 193 white cells, predominantly lymphs, and no hemorrhagic component, no red cells in the spinal fluid to speak of. So you don't have to have red cells in the spinal fluid in order to have herpes simplex encephalitis. And then, let's see, unable to advance. Her spinal fluid was positive for herpes simplex type 1 DNA. And it was thought that probably her initial syncope episode was likely seizures. I just want to make a remark about the PCR and the standalone versus the PCR in the meningitis encephalitis panel. The sensitivity, if it's in the standalone assay, is probably about 90% to detect herpes simplex virus by PCR. So it's a very sensitive and specific test. Unfortunately, the PCR that's done with the meningitis encephalitis panel has been compared to the standalone, and this is only about 70% sensitive. So what I would say to you is, if you do the meningitis encephalitis panel and the PCR for herpes simplex virus is negative, don't take that as necessarily as an exclusionary test, whereas the standalone can be used more or better as a exclusionary test if you do it individually. So the advice is, if you're suspicious about herpes simplex encephalitis and you've done the meningitis encephalitis panel for HSV PCR, you should repeat it and do it with a standalone assay, because that might be more sensitive. And the other lesson about this is you can do the PCR after the acyclovir has been started. Indeed, you should start the acyclovir if you're even suspicious about herpes simplex right at the beginning of the illness before you do all of your diagnostics. So bottom line is, don't be dissuaded from doing the PCR after the acyclovir has been started. So again, the mantra is to repeat the PCR and the spinal fluid in suspected cases, even if the acyclovir has been started. It's estimated that the PCR remains positive in up to 50% of patients for the first week of illness. So you can detect it. Again, it's not 100% sensitive. The other way to get at this is, if you have a patient who you're seeing later in the course and you're suspicious that they had herpes simplex encephalitis, and it's more than 2 weeks since the onset of the illness, you can do an IgG index for herpes simplex virus antibodies, comparing intrathecal synthesis of HSV1 antibodies versus the serum antibodies. And if the ratio is satisfactory, you can show that there is an elevation of intrathecal synthesis, and that's diagnostic for HSV1 encephalitis as well. The MRI scans are often much more involved than the case that I showed. Typical involvement is mesial temporal, uncal, anterior temporal, insular cortex, and orbitofrontal cortex are the typical places that are affected. It can be unilateral in its involvement or bilateral involvement. With herpes simplex, it tends to be asymmetric, and one of the ways to help distinguish the limbic encephalitis that's autoimmune or some of the other causes is that herpes tends to be very asymmetric in its imaging characteristics. And people argue about, can you have a normal MRI scan and have herpes simplex encephalitis? And I would say never say never, never say always, but the MRI scan is always abnormal in patients who have herpes simplex encephalitis. So that's the mantra that I learned to live by. As we talked about, acyclovir should be started early. The earlier the treatment, the better the outcome. The duration of treatment is a little bit still open for discussion. The initial prospective studies were done with 14 days of 10 milligrams per kilogram every 8 hours. Most experts now in patients who have severe encephalitis recommend 21 days. It seems to be accepted that that's the rule or the recommended treatment. Again, patients have severe forms of encephalitis with long-term cognitive outcome disturbances. So the idea is to try to do the best we can with the antivirals for as long as we can to give them the benefit of the doubt and better recovery. Because of the prolonged effects of herpes simplex encephalitis and the cognitive disturbances that are a result, there's been a trial with prolonged oral valacyclovir, which is the prodrug for acyclovir, which is bioavailable if given by oral route. John Gannon and the group from University of Alabama did this trial with the collaborative antiviral study group, and unfortunately the prolonged valacyclovir did not seem to provide any additional benefit in neurological outcomes. There is information now that's coming from about using herpes simplex and steroids. There were some early tries with adding steroids to the use of acyclovir at the beginning of illness, with the idea, like we use it for meningitis, that it would reduce inflammation and therefore lead to a better outcome. And I'll just tell you that there's now a protocol being executed in the UK with active enrollment of patients with herpes simplex encephalitis and dexamethasone treatment. And we should have an answer for this. They're well enrolled. A German study earlier had been done and was closed for insufficient enrollment. There's a parallel study with the same regimen being done in France and Sweden as well. So I'm hopeful that we will get an answer to this question that's been around for 20 years or more. There is this thing that's been called relapsing herpes simplex encephalitis, and this was emphasized by the Swedes in the early 2000s about patients having clinical relapses, often 1 to 7 weeks after the initial improvement after treatment for herpes simplex encephalitis. And again, when this was investigated further, particularly looking for NMDA receptor antibodies in the spinal fluid, it became clear that most of these patients had NMDA receptor encephalitis unmasked by the herpes simplex infection. So we recognize this now as a late consequence of herpes simplex. It's a patient that has worsening of MRI scan abnormalities. They have clinical deterioration, but their PCR is negative for herpes simplex in the CSF, and they have antibodies against NMDA receptor in the CSF, which again is responsive to immunotherapy, specifically steroids and other. I'll turn and briefly speak about autoimmune encephalitis, and just because of lack of time, won't talk much about this. This is an ever-expanding, complex series of disorders. The two that are most important that you can't forget about testing for are the NMDA receptor encephalitis and those that are associated with the former voltage-gated potassium channel complex, now known as Casper-2 or LGI-1 antibodies. This is a case that we had about 15 years ago, a patient who had limbic encephalitis, bilateral involvement of the mesial temporal areas, and responded well to steroids and other autoimmune therapy. There are an expanding list of autoimmune antibodies associated with encephalitis that I won't have time to talk about specifically, but I do want to talk about this one just because I was involved with it as it became clear, and again was another surprise. About 20 years ago, we were faced with patients who had a subacute to chronic encephalopathy. That is, it usually evolved over a period of weeks, behavioral change, amnesia, inattention. They had postural tremor and myoclonus. They had diffuse hyperreflexia. They had mild signs of myelopathy, often with central cord signal abnormality on the MRI scan. You can see it a little bit, the T2 signal involving the central cord. They had optic nerve swelling with papillitis without increased intracranial pressure. And the most characteristic MRI scan abnormality is this radial enhancement radiating from the ventricular surface. And this was associated eventually with a novel antibody that was found by my colleagues here and published in 2016 against GFAP. So if you take anything away, I hope that you recognize this entity when it appears in your clinic, because it is steroid responsive and responsive to other autoimmune therapy. So I'll conclude with that, just to review some of the things that I've mentioned. Most common cause for encephalitis in the United States remains viral. There's still significant overlap between viral and autoimmune encephalitis. They're about even. Headache and fever suggest viral. PCR testing is helpful for viral disease. There are some limitations. It's important to know those. There is a role for next generation sequencing. What its role and is it a first line sort of test to do is not yet known. There are problems with contamination. CNS COVID disease is probably not due to brain infection. It's probably mostly para-infectious phenomenon. New pathogens are appearing, things like Powassan virus, and old ones are spreading like Eastern equine encephalitis. Treatment for viral encephalitis remains limited to principally acyclovir for herpes simplex, but there are some other options, one at least to think about, with IVIG therapy for Eastern equine and so on. And recognition of autoimmune encephalitis is forever expanding. There's increasingly numbers of, and I won't show you the table that my colleague from Autoimmune Neurology here shared with me, with 30 antibodies and different panels that are now being executed. So I'll stop there. I'm happy to take questions, and thank you again for inviting me and letting me share some experiences with you.
Thank you so much, Dr. Aksamit. So that was a great lecture. So we had like in space for a couple of questions. Let's see. Someone can take the microphone, just you can do it.
I'm going to stop sharing just for, unless somebody, so that.
Can I ask a question?
Of course.
Thank you very much for the wonderful talk. We had, my question is about a patient that we had, a pediatric patient that was diagnosed with NMDA encephalitis based on the antibodies detected in CSF. She also had positive HHV6 in her CSF. So our conclusion, I mean, we were not sure what to make of that. We thought that it's possible that it's like either an incidental finding or maybe triggered autoimmune by HHV6. But now that you talked about the chromosomally integrated HHV6, I was wondering if that was the case for our patient.
Yeah, I would suspect that you're right. I suspect that this was probably a non-pathogenic HHV6 example. Again, because of the imaging overlap, HHV6 encephalitis causing a limbic encephalitis, autoimmune encephalitis, NMDA receptor encephalitis causing a limbic encephalitis. It's hard to sort out from an imaging perspective, but this information about HHV6 being potential false positive, so to speak, it's a true positive. It's just that it's not a pathogenic organism, and again, it's just one of those where there's not a easy way to do the molecular diagnostics to get that sorted out. But yeah, I would bet in your circumstance, which from what you described, it was probably an NMDA receptor encephalitis that was primarily responsible.
Thank you.
Can I ask a question, please?
Yes, please.
Thank you for the wonderful presentation. I'm a senior citizen and physician. We grew up with the thought of recurrent HSV, but now that we know better, so at this point, if we have a patient who's had herpes and who comes back again with what looks like a recurrence, can we, automatically say this is not recurrent herpes infection itself, but an autoimmune reaction? Should that be our approach?
Thank you for your question. It's a difficult one to answer in the sense that a little more detail, I think, is required. Herpes simplex encephalitis type 1 generally tends to be a monophasic illness. It doesn't tend to be recurrent. Again, when it's recurrent, so to speak, or subacutely recurring, it's now thought that that's probably related to an NMDA receptor encephalitis. There are other autoimmune antibodies that are also created by herpes simplex encephalitis when you assay in the spinal fluid. There are other antibodies as well. There have been other examples of patients who had other viral encephalitides who also have autoimmune antibodies that are created in the spinal fluid by sampling. Whether they're clinically important is unclear. Bottom line is, if you think that the patient is recurring from herpes simplex type 1, assay the spinal fluid for NMDA receptor encephalitis antibodies, and maybe do the autoimmune encephalitis panel in the CSF to look for other ones, because it's more likely to be autoimmune. The other part of the question, and I wasn't sure what you were talking about recurrent, is that HSV2 causes a recurrent meningitis commonly. And that one is more of a meningitis, not so much of an encephalitis, although rarely HSV2 can cause encephalitis. But the recurrent disease associated with herpes simplex is typically HSV2, and it's recurrent meningitis. And a lot of the old cases that we thought of as Mollaret's meningitis turned out to be herpes simplex type 2. And in my practice, that's the most common cause for recurrent viral meningitis that I find. And again, it can be a little bit elusive because the PCR is only positive in the first 3 days of HSV2 when the patient has meningitis. So you sometimes miss the opportunity to capture the virus. Again, this is one of those that you can sometimes get at by doing antibodies in the serum and CSF for HSV2 and doing an index and finding the antibodies being intrathecally synthesized and make a diagnosis of HSV2 that way. But yeah, so I presume you were talking about HSV1 or HSV2, or what's your thoughts?
Thank you for again clarifying. Most of us recognize that the HSV2 is the meningitic form and recurrence does occur. So that's a different, animal or beast, as I would put it. And for the HSV1, in the past, again, we've had where, patients come back and we had not, we had assumed, and this was pre the autoimmune, encephalitis era.
Right.
But this day and age, of course, having recognized it, but there's always the concern in my mind that, whenever we suspect viral encephalitis, the few treatable ones, herpes is one. So I always say, start the acyclovir and we will know, we'll be very smart 2 days later. So in this case also, in a recurrent episode of HSV1, even though I put my money on NMDA or receptor antibody, encephalitis, should I still, be a chicken and just go ahead and start acyclovir for 2 days and find out what the antibodies show?
Well, again, there's not much harm in restarting acyclovir, but in my experience and in the cases that we've seen and the ones that I've been burned on, the HSV PCR is always negative. And again, we've learned more about finding the antibodies in the spinal fluid associated with worsening MRI. And those patients respond well to steroids. They do well with high dose IV methylprednisolone, short course, 5 days typically, and then oral taper afterwards is the typical thing that we do for those patients.
Sorry to prolong the discussion on this. The steroid business, again, is double-edged in meningitis and encephalitis when we are not treating specific, organism. So I'm always hesitant initially. We put them on high-dose steroids. I'm saying, what if this is the case where, I'm faced with and then realize 2 days. So that's the only concern.
Sure. Well, the other side of that, of course, is that as I said, there's a trial going on using dexamethasone to treat herpes simplex encephalitis to see whether it can lessen the severity of the long-term injury. Again, some of the long-term injury is being assumed as being this autoimmune effect or this para-infectious effect of the virus inducing injury to the inducing an immune response and damaging the nervous system as a consequence of the autoimmunity aspect of things. So hopefully, again, we'll have an answer to the dexamethasone question, and I think it maybe provides a little more buffer for you over using steroids in the phases of maybe a late recurrence.
Thank you so much.
So I think that this is for today. Everything, Dr. Aksamit, thank you so much for all wonderful presentation, the discussion. And I think there is always more questions. I think like if anyone has any other questions, just like email Dr. Aksamit with any further, I can provide that information. Thank you everyone for participating today, and see you next time and next Friday.
And my email is easy. It's aksamit@mayo.edu. So thank you.
Okay, bye-bye.